So, hello everyone, I am Elisabeth Paul from the School of Public Health of the Université Libre de Bruxelles, ULB, and I'm going to speak about vaccine equity and question the fact whether it is a step towards decolonization or rather if it's going to perpetuate power imbalances. As a background, we know that worldwide the vaccination against COVID rates are very different. For instance, Africa is lagging behind with about 30% of the population vaccinated against COVID-19, which is far below the rates encountered in Europe or in other countries like Japan or Chile. So at the global level, the global health institutions have coined the term vaccine equity, which has become a global target already set by the WHO in 2021, when the WHO wanted to vaccinate 70% of the global population against COVID-19 by mid-2022. This target has been revised since then. It has not been reached, but now it is more focused on the more at-risk population. Nevertheless, most of the UN agencies and global health organizations have embraced that objective of vaccine equity. This term vaccine equity has been presented as a fair or a right contributing to equity, both at the global level, but also at the national level. You see here a couple of examples of institutions like Save the Children or the European Public Health Alliance, which call for reaching vaccine equity, and they claim that all people deserve the opportunity to receive a vaccine against COVID. At the national level in the USA, the CDC has also embraced that objective in order to reduce the inequalities with regard to race and ethnic minorities. Of course, there are also other justifications to vaccine equity, to the global target of vaccine equity, and notably because the global north is a bit afraid, and the global north understand that no one is safe until everyone is safe. This is the mantra of COVAX, the international facility which has been set up in order to facilitate the distribution of COVID vaccines in the global south. And it's also presented as a means of recovering the economy at the global level. But now vaccine equity has been adopted in common language. You see that there is now a Wikipedia page on vaccine equity, recognizing that this term has been coined for the first time in relation to the COVID-19 pandemic. And many academics now have embraced the concept without questioning it at all. You see a couple of examples of papers on by academics on vaccine equity in low and middle income countries. But all along, this objective of vaccine equity is presented as a moral imperative and perhaps also a step towards decolonization, which is very fashionable at the moment. And Tedros, the Director General of WHO, has particularly promoted that equity, and he claims that it is a catastrophic moral failure not to not to ensure COVID-19 vaccine equity. But what is it all about? What is that concept of vaccine equity? In a paper written with David Bell, a colleague of mine, we question that concept. We all know that health equity is a very valuable principle of public health. And what is it all about? It is about addressing the causes of health inequalities and disparities that are avoidable, unnecessary, and unjust. That is to say, health equity means that everyone in the world, depending on be it of every age or every race or every nationality, should have equal access to health interventions depending on their relative needs. So health equity, is about equal access for an equal need in terms of health. It is not at all about equal access to a specific health technology, which is about vaccine equity, so having all the same access to that particular health technology. Now I would like to question the fact that vaccine equity is a good thing. I will first argue that the expected benefits from the COVID vaccines are not that good, and then I will also speak of the costs. So in terms of expected benefits, COVID vaccines should be considered in the framework of the overall burden of disease of low and middle income countries, and especially in Africa, which is the focus of my presentation. So we know that in Africa, the burden of disease is heavily impacted by a lot of different diseases like HIV, TB, malaria, but also sexual health, malnutrition, and also non-communicable diseases. So COVID-19 may not be one of the priorities of African countries. We also know that in sub-Saharan Africa, 50% of the population is below 19 years of age. And we know that the median infection fatality rate of COVID-19 for that category of age is 0.0003%, which is very negligible. Moreover, we know that Africa has a very high level of acquired immunity and seroprevalence. The seroprevalence of SARS-CoV-2 was already of 2/3 of the population in September 2021. And now, by the end of 2022, it was over 90%. And we know that the protection conferred by natural immunity is very high, about 90%, and it is lasting, which is not the case of the vaccine-induced immunity, which is waning quite quickly. And the vaccines are not effective against the current variant, the Omicron variants. I recently read a paper which assesses the vaccine effectiveness of 4 doses of vaccines against Omicron in naive people, and it was something like 16%, very negligible. On the side of the expected costs of COVID-19 vaccines, first we have to take account of the monetary cost. To date, the COVAX facility, which was set up, as I said, to facilitate the distribution of COVID-19 vaccines worldwide, already $16 billion have been committed to it. And it is expected that if you want to vaccinate the whole population of the low and middle income countries against COVID, it will be very costly. There is an estimation of something like $61 billion for 3 doses of mRNA vaccines in LMICs. So that means that those monetary costs will also be some opportunity costs. They will divert resources from other health priorities, which may be more impactful in terms of burden of disease in African countries. There will be also health system disruptions and costs, for instance, all the human resources, the supply chain management, etc., which will be mobilized to deliver the COVID-19 vaccines. And it's also important to know that there will be some costs to manage the adverse events. There are not many risk-benefit assessments of COVID-19 vaccines, but 2 recent papers have estimated that among young people, there would be more hospitalizations in the US due to COVID vaccine adverse events than those hospitalizations prevented by the vaccines. And another study by Krug and colleagues in Europe also estimates that the risk-benefit analysis is not in favor of COVID vaccines, except for non-immune girls with a comorbidity. Among other categories of young people, it's not good value for money. So as a conclusion, I will argue that imposing a global target on COVID vaccine has nothing to do with equity, and it has nothing to do with decolonization. And on the contrary, it risks to foster health inequities and also to perpetuate power imbalances between the global north and the global south. And I would say that it is high time for African countries to choose their own health priorities. This should be done through evidence-based deliberative processes, instead of being imposed what health interventions they can get and what result they should achieve to meet the global targets set by international institutions. But it is still a very important taboo in global health, as I can tell you, because we, with some colleagues, we have a paper trying to be published for over 1 year on the subject, and it's very, very difficult to get it published. So I would be very interested in discussing with you after this, the presentations, to know what you think about this target of health equity. Thank you. And here are my references.